Yeah, so I have just kind of a handful of slides so that the graphs from the research that we've done are visible and people can kind of see. I think it helps to actually be able to visualize the numbers. So, we're all talking about this because of the proposed infant conversion that's approaching very, very quickly over the next couple of months to, almost the beginning of 2022. One of the biggest populations where we still have some remaining clinical concerns, especially regarding the infant Lotus tip, is within the neonatal population. Okay. And to frame, again, for the rest of the talk, the kind of the important ISO standards that we'll be speaking about include 20695, which incorporates the small bore connector requirements of ISO 80369-1 and 3. 80369-1 are just the general requirements for small bore connectors that are utilized to deliver liquids or gases within a patient care setting. And this is the standard where the goal is really to increase patient safety and reduce the risk of these inadvertent misconnections between unrelated systems. 80369-3 specifically applies to the enteral system. So there'll be a little bit of this touched on throughout the rest of the talk. One of the things that came out in 2018 was the FDA letter to healthcare providers, where they recommend for the healthcare professionals to check the labeling or check with your distributors or manufacturers to determine that your connectors meet the ISO standards. And then the recommendation the FDA made for hospital purchasing departments and distributors specifically related to enteral devices and the need to comply with 80369-1 or 3 to reduce the risk of enteral misconnections. And then for those of us who are also familiar with the ISMP best practices, the latest one from 2020-2021, best practice 4 relates to the use of oral or 80369 compliant syringe tips. And they want us to ensure that all oral liquid medications that are not available as a unit dose are dispensed by pharmacy and oral enteral syringes that meet the 80369 standard. So some of the biggest concerns that we have related to the infant Lotus tip include accuracy as it relates to medication administration, complexity as it relates to oral adapters, and safety as it relates to enteral tube infection control. And we'll get into pieces of each of these during the rest of the talk. So one of the important parts that I always want to make sure we're on the same page about are target dosing accuracies for our oral and enteral devices. There is no standard, there is no set number that we know of or that's utilized with the oral and enteral syringes, but during the original infant industry sponsored testing, they utilized a plus or minus 10%. There's also no standard within the clinical community for acceptable dosing variance, but there's been at least a couple of papers published related to kind of where that plus or minus 10% may come from. But as you can see on the right-hand part of the screen, as we are moving into medications that have higher risk of toxicity or have potential for unintended or harmful effects, that dosing accuracy must be even more narrow than plus or minus 10%.
Would be great. I'm just not sure who controls how.
So we actually did, within the last month, an in vitro study here at Wakeman Health and Hospitals, where we compared female enteral medication syringes. And this included both the NutriSafe 2 as well as the NeoMed Infant Lotus Tip. And we had about 150 syringes total in each of these. And you can see how we divided those up between the 0.5, the 1 ml, and then 2.5 for the NutriSafe 2 versus the 3 ml for the NeoMed. We also looked at the performance with high and low intended volumes of the syringe capacity, because we know that oftentimes the lower volume in the syringe may be less accurate. We used the FDA approved instructions for use for each syringe, and we tested children's Dimetapp cough and cold just to have an oral liquid medication with a kind of consistent viscosity and such. We use the bulk bottle adapters and medication cups as our dispensing mechanisms, because this emulates what you see both from dispensing from the pharmacy as well as potentially bedside administration for nursing. We looked at the actual dose versus the intended dose to determine what the dosing variance was, and we considered any test greater than 10% to be unacceptable. With our sample size calculation, we needed at least 104 tests in each arm to detect at least a 15% absolute reduction in the primary outcome. And again, we tested 150 just to make sure that we had a little bit bulkier of numbers with our testing. So for the primary outcome, looking at dosing variance greater than 10%, the infant low-dose tip syringe, 48% of the test fell outside of a 10% dosing variance as compared to 4.7% with the NutriSafe 2. The overall mean dosing variance was significantly different as well. So it was 11.9 plus or minus for the infant low-dose tip versus 3.3% for the NutriSafe 2. So overall, the NutriSafe 2 showed significantly lower overall dosing variance, and the infant low-dose tip was more likely to result in higher than intended doses. Sorry about the overhead calls. The infant low-dose tip, when we look at it with our 0.5 versus 1 and our 2.5 and 3 ml syringes, we found that dosing variance was significantly worse at the smaller syringe sizes. So for the infant low-dose tip, the 0.5 ml overall dosing variance was around 16%, and then the 1 ml syringe was around 10.7%, and the 3 ml brought it down to about 8.8%. This is a comparison to the NutriSafe 2, where with the 0.5 ml syringe had a 4.6% overall dosing variance. The 1 ml had around a 3%, and the 2.5 ml also was around 3%. So you can see this is much tighter of a range with the NutriSafe 2 as compared to the infant low-dose tip. We also, again, compared out the bulk bottle with adapter, which is what you would see mostly coming from pharmacy as prepared syringes versus medication cup, which is more of the unit dosing that you might see prepared at the bedside by the nurse. So with the infant low-dose tip with a bulk bottle with adapter, 13.3, there's an overall dosing variance of 13.3% versus 3.9%. And with the medication cup, the infant was 9.7% dosing variance as compared to 2.9. So one of the big issues when we're looking at dosing and accuracy is the NICU is the ability to diagnose this, because these patients are nonverbal. They can't tell you when they're feeling poorly or if they're having signs of toxicity or of signs of underdosing. And these symptoms are often very subtle. And oftentimes we are using this as a diagnosis of exclusion. So if a baby has been stable on a medication and then we see that they're no longer acting the same way, we're running through a million different potential reasons why they may be presenting as they are. And very rarely, unless we know that there's an accuracy with our utensils, we're not going to assume that the device is the cause of the problem. So one of the things that you could potentially do if you were to suspect dosing inaccuracy in the neonatal population is you could draw blood levels, but those aren't available for every single medication, and this often may lead to unnecessary blood draws. We try to really avoid painful procedures since this can have long-lasting neurodevelopmental changes in the preterm infant. And again, most of these medications actually don't have an associated laboratory assessment, and so that makes, for the majority of the medications, drawing a serum concentration not feasible. So one of the biggest keys to this dosing and accuracy piece is we need to have clear communication of this risk to the providers and the staff. The staff need to be well educated, and we really need vendor transparency to the clinical community where these devices have risks of dosing inaccuracy. There are a lot of issues with complexity in medication safety as well. So we know that the more complex the process, the more that we may see medication errors. This leads to variation in practice and overall increased risk of patient harm. We do know that reducing complexity is the key to improving safety and productivity. And some of the key components of that are to simplify and standardize the process. And always remembering that every step in a process is an opportunity for error. So just looking briefly at the Lotus Tip Adapters, this is a piece that is novel to the infant system. NutriSafe 2 and the male legacy devices do not require oral adapters for use, either for ability to administer orally or for dosing accuracy. And this is something that's a little different when we look at the infant low-dose tip, where the oral adapters are recommended to be used through the entire process. So if we're looking at the complexity of use and the number of steps that it takes to complete filling with a Lotus Tip syringe, you can see that the DoseMate instructions for use say to screw the adapter completely onto the syringe, but there's no clarification for the bedside provider in terms of how to address this for a bedside fill versus a pre-filled syringe. So pre-filled syringe being, again, that kind of standard pharmacy dispensing versus the nurse drawing it out of a cup. When we look at our DoseMate DL, the straw type adapter, we have additional instructions for how to use these. So we're supposed to screw the adapter completely onto the syringe prior to drawing up from the medication cup. So this would, again, bedside fill, be representative of what the nurses are having to do. For the pre-filled syringes or the pharmacy prepared patient specific, they recommend screwing the adapter completely onto the pre-filled syringe. So it would come from pharmacy with a cap. And they note that there is approximately 0.1 mLs of priming volume and that air flushing may be used to fully expel the syringe contents. And this is important because when we look at the legality of may versus must and shall and will, so it's not dictating that the nurse or the provider must air flush. And this is an important note for how the accuracy works when we add in some of these adapters. The manufacturers do recommend that the dosing accuracy is maximized when these oral adapters are used throughout the entire process of filling, plunger operation and dispensing, and then administration to the patient. And so again, when we're looking at oral adapter use as it pertains to pharmacy filled patient specific syringes that are capped with the appropriate cap, we're not going to be able to assure that this adapter is used through the entire process for the most common way that most of these medications are dispensed to the NICU. So another study that we did previously at my former institution, which was the University of Florida, and the original one that we did was evaluating the Lotus Tip dosing accuracy with the use of the adapters. So similarly to the study that we completed comparing it to the NS2, we looked at it as compared to the Baxter Male Legacy syringes. We also looked at the Neonatal Legacy syringe and then the Neomed Infit syringes, both in Lotus Tip 0.5, 1, and 6 mLs, and then the standard or classic Infit syringe at the 12 mLs. And again, we tested these lower and higher volume capacities. Similar instructions that were followed. The caveat to this being we also looked at 81 milligram chewable tablets crushed and mixed with water, since we know that that's another potential way that we sometimes have to administer medications both to babies and to older kids. And what we found with this was that if you look at just the mean dosing variance, it's 3.9% with the male legacy versus 8.1% with the infant Lotus Tip. So it looks like it's within that plus or minus 10%, which is great, except for if you look at the spread and the precision with the use of the adapters, you can see how wide that distribution is. And so even though it looks like overall they're within a plus or minus 10%, the amount of variability is incredibly high with this device. So when we broke it down by syringe size, you can see that the infant is in the orange and the male syringes are in the blue. Based off of overall number of tests that fell outside of a 10% dosing variance, it was 21.2%. When we looked at the low volume syringes, so specifically looking at those with the Lotus Tip, it was closer to 26% of all tests had greater than 10% variance. And then specifically looking at the 0.5 ml syringes, almost 40% fell outside of range versus 26.4% with the 1 ml. So we can see that similar to what we saw with the study we did versus the NS2, that the smaller syringes are more vulnerable and that the overall accuracy is fairly poor. So kind of wrapping up what this syringe performance data summary looks like, the NutriSafe 2 syringes appear to have a comparable dosing accuracy to the male slip tip syringes. So for facilities that are currently still using legacy devices, the NutriSafe 2 in the neonatal population should get you roughly the same performance. The infant Lotus Tip syringes have a greater dosing and accuracy when compared to male slip tip and the female NutriSafe 2 syringes. And it's important to note that the final version of ISO 20695 does reflect the failure of the Lotus Tip to correct the known accuracy issue of the classic infant. And so this is no longer included in that standard. Without adapters, so the study that we did as compared to the NS2, we saw that there was actually greater precision compared to the use with adapters, but that the overall accuracy was impacted by this, and it tended to result more in overdosing, which is of course a risk for toxicity. When we're looking at the testing that was done with the adapters in the Lotus Tip, there was a decrease in precision. You did have a somewhat improved accuracy, but for those tests that fell outside of the plus or minus 10% range, they tended to fall greater outside of the 10% range than when we did not use adapters. Of note, the use of adapters often was more prone to underdosing, which could lead overall to treatment failure. So then when we're looking at moving into our infection control, enteral tubing contamination piece, we do know that enteral tubes are often left in place for extended duration in our neonates. And we know that the insertion can cause measurable distress in preterm infants. And so that's something we really want to try to minimize. So we don't recommend routinely changing these out daily or every 2 days. We really want to try to maintain them in a manner that's safe to help minimize pain. We also know that these enteral tubes are a source of bacterial exchange between the baby and their surroundings. And it's felt that this is most likely due to the milk that we're feeding them, the infant gut, and then environmental sources such as caregivers or just contaminated equipment. Biofilm containing bacteria can develop within a single day after insertion of these tubes. And one particular study found that more than half yielded pathogenic bacteria within that biofilm, and that the duration of the tube placement did not correlate with presence or density of contamination, meaning that whether the tube was in 1 day or 14 days or 21 days, that did not impact how many were contaminated with pathogenic bacteria and how much of those bacteria were present. Another enteral tubing contamination study found that nearly 3/4 contained organisms isolated from biofilms on the tubes, and that this occurred regardless of the type of enteral feeding formulation. So it included both human milk as well as what should have been sterile formula feeding. And the concern with this is, of course, that you can bolus bacteria into the stomach with each feed, which most neonates are feeding every 3 to 4 hours. And so this is a significant burden over the course of their stay. So looking specifically at infant enteral tubes, at least with the Neomed tube, they recommend an indwell time up to 30 days. And there is a cleaning recommendation, which includes removal of medication and formula debris from that inner ring of the tubing, and that the frequency of this depends on patient factors, one of which is how often the tubes are being accessed and used. So there is a recent study that looked at infant cleaning procedures of these tubes, and they compared what they considered a more diligent cleaning regimen as compared to a less diligent cleaning regimen. And you can see, excluding kind of step 1 where you're gathering supplies, which there's anywhere from kind of 5 to 6 supplies needed to perform this regimen. The more diligent one is around 16 steps versus 8 steps with the less diligent regimen. And in this study, they performed a total of 114 tests of the more diligent, 122 of the less diligent, and they divided up the cleaning mechanisms as the infant brush, which is considered a single-use device, versus toothbrushes, which have been used more than once, up to, I believe, 28 to 30 days. So the interventions for this is they looked at a visible chocolate-flavored enteral formula that they could coat the tube with, and then an invisible substance called Dazo that requires UV light in order for the viewer to be able to see it. Nurses were assigned to one of the cleaning regimens, so either diligent or less diligent. And then after they were cleaned, they were graded on a scale of 0 to 2, 0 being no remaining residue and 2 being significant residue. The evaluations were done by nurses who scored their own cleaning process, and then independent blinded investigators who scored them after the nurses had completed this. So when we look at all conditions and all tests, the diligent arm had about 70% considered still contaminated versus about 87% in the less diligent group were considered contaminated. The chocolate formula that was visible to the eye, less than 50% were considered clear in the diligent arm. So we had, or about 60% were considered clean versus about 80% in the less diligent arm were still considered dirty. So only about 20% were cleaned. And again, that's with the visible eye. And then looking at the nursing evaluators, they tended to see that their products were cleaner than what the blinded investigator did. So the nurses saw that only 16% were still contaminated versus 25% in the less diligent arm. The blinded investigators found that 70% were still contaminated versus 84% between the diligent and less diligent. So this shows that the overall effectiveness of the cleaning procedures seems to be poor, that the caregiver perception of cleaning procedures is markedly higher than unbiased evaluators. So they got done cleaning, you're like, yep, did a great job. And when they had somebody else look at them, they did not have that same vision. The clinical implication of the contamination is unknown, but risk cannot be ruled out. All of the tubing information we talked about earlier related to traditional legacy tube lines. And so we know that even our normal enteral tubes are at risk, and that's without requiring a cleaning procedure. So it's even more concerning when you have tubes that are prone to overall contamination. So in summary, with our enteral tubing, we know that neonatal enteral tubes sequester potentially harmful bacteria, that colonization and biofilm development happens within 24 hours. And again, those infant enteral tubes can dwell for up to 30 days in the neonatal population. We know that medication and milk debris can build up in the infant tubing hub, that these cleaning protocols recommended may not actually be effective, and that self-evaluation of the cleaning procedure may overestimate actual performance. So really what we need are more studies to evaluate the impact of infant enteral tubing contamination risk in neonates. And it is important to note for this as well, routine cleaning protocols are not recommended for either the NutriSafe 2 line or the traditional legacy line. So again, this is something unique to the infant tubing system. So looking at what the clinical impact of infant looks like within the NICU, we know that we have decreased dosing accuracy with the infant Lotus Tip compared to alternative devices. The risk of under and over dosages are based on the methods utilized, so the use of adapters or not. And it's a fairly complex training process that must be rolled out to medical staff as well as family members. And it's not something that's insurmountable, but when we're risking potential over and under dosages in a fragile population, it becomes incredibly important to make sure that anyone using this is very well trained. Looking at the operational impact for infant in the NICU, with the introduction of oral adapters, it is recommended to be used throughout the entire process. So with the pharmacy, this is not possible to achieve with our patient-specific syringe doses because whatever adapters would potentially be used to draw out of a bottle or a cup or some other dosage formulation, we have to put a syringe that will cap it to not allow the contents to expel so that it may be delivered to the unit. And so we're not going to be able to do that with a straw or with the nipple adapter. There's not a cap for those. For nursing, this requires additional storage space, and most NICUs that I've been in usually have stuff crammed everywhere. And so trying to find another spot to house oral adapters may be somewhat problematic. And then there are also specific steps that must be followed for bedside administration, including air flushing and remembering to do all of that. For the supply chain impact, you're looking at increased supply ordering and cost because, again, oral adapters are something unique to the infant system. They're not something that the traditional user of a male legacy device or a current user of the NutriSafe 2 would be used to having to utilize. And then there's also the introduction of the tubing cleaning procedures, which are recommended to be completed with each access. So when we're looking at things like a neonate who eats every 3 to 4 hours, this becomes several times a day, and then also cleaning when visibly soiled. Although this has no direct impact on pharmacy, on our nursing colleagues, this is introducing a new cleaning process, again, up to 6 to 8 times a day. That's not something they're used to doing. And it requires the need for brushes and supplies. And so if we're talking about something like the single unit or the single dose, single use brushes that are commercially available, this is, again, trying to find the storage for this and the place for that and remembering to grab one before you're going to go in and access the baby's tube. So it's just, or if we're using a toothbrush that we're using for several days to weeks in a row, how do you store that? Where does it go? Where does it live? How do we keep it from getting mixed up with other things? And then for our supply chain operations, we're also, again, looking at increased supply ordering and cost related to either needing to order the single-use brushes or additional toothbrushes. So for some of our key takeaway points, the male slip tip and compatible tubing availability is being phased out by enteral device suppliers in the US. So we really need to start thinking about how best to serve our most fragile patient population. It does not appear that the infant addresses the specific needs of neonatal patients. And again, ISO 20695 acknowledges the failure of the Lotus Tip to reliably deliver accurate doses over the known dosing and accuracy in place with the classic infant syringe. The tube cleaning protocols appear to yield low results. And then our NatureSafe 2 was designed specifically for neonatal patients. It has superior dosing accuracy when compared to the Lotus Tip, and there is no tube cleaning protocol required and no required use of oral adapters. So at this time, I can take any questions anybody has.
So right now we have Janet and Karen. Karen, thank you so much for getting on late. Appreciate it. Feel free, the two of you, to ask questions, or even Mary, Ty, or Evan. You know, there's a lot of information here. The question actually that I have, Dr. Omara, is concerning the biofilm. So I'm not that familiar with it, I'll be honest with you. Could you, and you said it came from human milk, it can come from human milk and formula?
Yeah, so in the one study, they actually found that regardless of the source, so we know that human milk has bacteria in it.
Right.
And you know, especially fresh mother's milk will have different skin bacteria or bacteria in the milk itself. And so that's not something that's unheard of. But they actually found in the one study that even sterile preparations of formulas, regardless whether you use that or human milk, the biofilm colonization happened. So,
and what exactly does the biofilm lead to? I guess what is it? I should probably know this, but I don't. Sorry.
Basically, the plastic is sticky, and so you get the little sticky bacteria-filled kind of colonies living on the plastic. And so if you have things like your enterobacteria and other pathogenic bacteria that they found in previous studies can happen, it sets the baby at risk for sepsis, necrotizing enterocolitis, and other potentially devastating consequences.
So the biofilm sticks to the inner diameter of the tubing, the feeding tube.
Mm-hmm. They found it all the way to the top. So when they do these studies, they'll take off the connector piece and take it in usually 1 to 2 inch chunks and look across the whole tube. So that's why we know it doesn't just come from the gut of the baby. They found it at the end of the tube that's outside of the baby as well. So that's where it's particularly concerning with the infant tubing in this population, because you have sticky oral sugary medications going in there. We have, you know, bacteria containing mom's milk going in there. And it just can make a perfect storm of feeding these bacteria and being trapped in spaces that set the tube and baby at risk for potential infection.
Okay. And I have a question for Janet and Karen. When you guys deliver meds to the baby on the floor, in the NICU specifically, are most meds given PO, or are they mostly given through the feeding tube?
And I think for both of those, they did not see great outcomes with the DIRACs. So
sorry, I had to figure out how to unmute myself again. It depends on the baby, but a lot of them are given through the feeding tube. If all the feedings are being given by feeding tube, you're going to give the meds that way too.
Okay. Would you say it's like maybe 50-50 or like 60-40 or?
I have no idea.
No, okay. I was just curious. I was curious as to see if it was different for babies versus adults and pediatrics. If,
yeah, probably.
Okay.
And some babies are getting both, you know, bottle breastfeeding and tube feedings. It's a combination. So, but I think medications would be kind of the last thing that we would switch over to giving by mouth.
Okay.
Yeah, one of the important points with this too, you know, I went back and looked at my previous institution at a chunk of the low birth weight preemies, and on average, assuming things go okay, they only have IV access really for the first kind of 10 to 14 days of life, and then they're strictly having their enteral tubes. And so the risk, the time frame of risk with having both an IV and an enteral tube, that are overlapping is fairly small when we think about the 3 to 4 months of a baby maybe in the NICU, and the rest of the time, most of that they're working on, they really can't start even working on enteral feeds until they're probably at least 32, 33, 34 weeks, depending on how preterm they were and how many problems they have. So the vast majority of their stay, they're receiving enteral medications and enteral feeds. And so that daily risk of dosing inaccuracy with a device that doesn't perform well is much higher than their overall daily risk of a misconnection. So I think it's important for people to remember, yes, we absolutely want to prevent misconnections, but the risk of dosing inaccuracy on a daily basis of what these kids are seeing is actually quite high. And so if we are using a device that the performance has, upwards of 50% of the doses being wrong.
One of the things that you said, Dr. Omara, and you might have said this in the previous webinar, and I apologize if I just missed it, but you mentioned that because the babies can't basically talk and tell you what's wrong. So I'm assuming like clinicians on the floor, they look for different signs that maybe they're not tolerating their feed or they're not tolerating their medication or things like that. I think that's a really good point because you might have somebody who has switched over to ENFit in the NICU and they're like, oh, we're not seeing any dosing issues, but has there been an increase in intolerability for whatever reason in your babies? Are you noticing a trend or something like that? I think that's a very good point that you brought up. I had never thought of it that way.
Yeah, and the sick preemie or the preemie that doesn't feel well isn't the angry 2-year-old that screams at you when they don't feel well. They get quiet and withdrawn, and so it's very hard in this population to actually be able to pinpoint the exact thing that may be causing the patient's clinical deterioration.
Mm-hmm. Hi, Michelle. Thank you so much for getting on.
Hi, sorry I'm late. I had a COVID problem in the unit.
No problem. We appreciate you getting on. Now, Dr. Omara just kind of briefly went through her presentation. I know that you and Sue really were the two that were really interested in talking with Dr. Omara. Do you have any questions or is there anything that we can address for you right now?
No, for NICU, for the LA County, we did not have any questions. We're using the product. Our biggest issue has been when product is not available due to delivery issues, and that hasn't been on your end. That's more with our middle, our LUM deliveries. We haven't had any problems. We're still very happy with the system itself.
And how long have you guys been using the system?
Oh my goodness. I want to say since we came here, so at least 10 years.
Yeah, I was gonna say about a decade or so, I think.
Yeah.
Oh, that's great.
And Michelle has been awesome enough to fight for keeping her system, like I think at least 2 times, if not 3, since I've been here.
So, Michelle, one of the things that have come up with the ENFit system is actually cleaning of the moat. And since you have been using NS2 for 10 years, can you give me feedback on if you've ever had to clean the moat or if you ever see feed in the moat, or if it's ever been an issue?
You know, it has never been brought to my attention by the girls that are actually using it. I'm not in there feeding very often, but they have not brought up that it's a problem. I can check.
No, you would hear if it was a problem, because that's probably the one thing when NICUs switch over to ENFit, that problem, they'll see that within the first week or so, or first couple of days actually, of having to clean it. So you would have heard something by now. That's why I was just curious, since you've been a long time user of it, what your feedback would be with it.
And that's part of that 16 or 9-step cleaning process every time you access? Wow.
Yeah.
Okay, gotcha.
And I can tell you that at my previous institution in University of Florida, we were at the Gainesville campus, and the Jacksonville campus ended up converting. Gainesville stopped our conversion kind of last minute because of the dosing accuracy concerns. And within a month, they switched back because of the cleaning process, and infection control got involved, and they didn't feel that it was safe. So that is a serious, from a nursing perspective, a serious concern.
So the 3 real big things are going to be the dosing inaccuracy for sure, the cleaning procedure and the storage issues with how the Lotus Tip kind of works. And then third, I find that a lot of people feel like when they go hospital wide with ENFit, that they're lowering their SKU numbers, but the ENFit low dose syringe is its own SKU number, correct? So effectively they have the exact same amount of SKU numbers pre or post, I guess, maybe Biofilm Company, but you still have just as many syringes per se.
Yes, and then all
Yeah.
the additional parts that you have
Parts,
to
yeah.
have with the infant.
Right. Okay. Gotcha.
Dr. Omara, this is Ty, one of the other reps in Los Angeles. I just wanted to clarify, we talked a lot about overdosing, but according to the ISO standard, there's a 0.15 ml volume displacement with the infit connector. So if a NICU is doing an administration of, let's say, morphine or digoxin where it has to be exact, and let's say it's 0.03 infusion, or what they're trying to infuse would be a 0.03, are they effectively, if they're using an infant connector, overdosing by almost 500% every time they're making that connection?
Potentially, yes. So that is, and we did some testing of our own to see how much that moat would fill, how much it contained in that Lotus tip. And so it was from anywhere from 0.15 to 0.18. And as we know, the classic female tip was 0.2 mLs. So they saved us 0.02 to 0.03 mLs by adding the interior male lumen. But yeah, certainly if you're trying to give 0.03 and you've got drug inadvertently around the moat, you can potentially more than 100% overdose these kids.
And that would be before you even push down on the plunger. That would just be as you make the connection. Before you even infuse it, you're overdosing by that much. And you're doing that, what, 4 or 5 times a day, right?
I mean, morphine, if you're looking at a neonatal abstinence baby, you're looking at 8 times a day.
So 8 times a day, before you administer the drug, you're overdosing by hundreds of percent.
Yep. And it's also important when you think of like the babies getting HIV meds for maternal indications and trying to prophylax against that. If you're potentially overdosing and causing significant side effects, or underdosing and not giving adequate coverage. So there's a lot of, the thing I kind of hear the most from people who don't work in NICUs is like, oh, well, neonates just get caffeine. What's the big deal? So there's, I think, a lot of lack of understanding of the types of medications that are given to babies in the NICU.
Okay, thank you. So, Michelle, we're not trying to convince you to purchase NutriSafe 2. We're trying to help you, give you the information you need to keep it. So is there anything you're looking specifically from us that you'll be able to, when we're not in those appointments behind closed doors, that you'll need to kind of persuade, purchasing and administration to allow you to keep NutriSafe 2? Is there anything specific you need?
No, I think I have the 2 points that I need, which remain the same 2 points. The cleaning process, now being 12 steps, is going to be much more work. We are not having any cleaning with our current product. And then the dosing process has always been the issue for us. And I will push that strongly.
I really appreciate that, Michelle.
All the all the HIV positive kids down here.
Right.
And Michelle, if the rest of the hospital wants to go ENFit, like in your pediatric and your adult populations, we can connect the 2 systems. You'll have a little bit of overflow into peds, but that'll be about it. And we will be coming with an ENFit system for Vigon itself, probably about the September timeframe. So you have the opportunity to have one vendor with 2 separate systems that are safety systems that are ISO compliant that will fit your specific patient populations. So if that's a concern of supply chain, we'll be able to connect with whoever you go with ENFit. But just so you know, we will be having our own ENFit for the older kids and the adults later this year.
Okay.
And really the main, that's awesome too. And I guess the big thing too is just want to make sure that no one feels like we're trying to throw a huge wrench in the top-down conversion, that our absolute main goal is to protect your specific patient population with the correct system. If the 94% of the hospital changes to ENFit, it is a good move for them to switch to some sort of reverse locking lure for safety. I totally agree. Just the correct one for you. So I just want to be able to make sure that when you go to battle, that you don't think we're trying to put a wrench in the other 94% of the hospital. Just your little portion is all we're really kind of trying to
Right.
raise.
That's all that we're trying to ask for.
Yeah, exactly. Yeah.
The
And
rest of the world.
I feel bad that Susan was able to make it. I called her this morning. She was good to go. And then right when I called her at 11, she said Jaco walked in her front door as she was signing on. So she had to make herself available.
Thanks for sharing that. They
Yeah, so
usually
I know.
have
So it's a
that
total bummer.
together.
Yeah, I know. It's just she's the kind of the one who seems to be an immediate attack, if you will. Something like in the next 2.5, 3 weeks, she's supposed to start swapping out. So I'm super bummed I don't have the same influence with her on this presentation, but I just want to make sure I get that to her the best I can. Any advice that you maybe have of what's best? We did record this. We do have another version of this as well that I'm going to send her. But I guess any coworker push, if you will, of importance is very
Sure.
helpful.
Yeah, of course. I can reach out to her.
Yeah, it's awesome. Janet, did you have any questions? I know this was kind of a lot, maybe a lot for you as you don't use this system currently, but now you kind of have an idea of what might be coming down to you top down and some of the concerns that why Sue and Michelle fought for a decade to keep it. Just want to make sure that I guess we answer your questions and you feel good about when that does come to you, that you have some help, and we'll always be here for it, obviously, but.
Yeah, no, I think I understand the
Great
reason why you guys, why this is a good system. But it definitely, I think, Karen, you said you would be sending us the webinar so we can share it with people, right?
Yeah, absolutely. I'll get you guys the recording once Zoom puts it together, and then I might edit it, the little front part out.
Yeah.
But besides that, I think, Dr. Omara's information is just so important, and the more people that we can educate on that, the better. And please feel free to share it. We'll probably post this. We do have Vigana has a YouTube channel. Dr. Omara's last webinar was posted on it, and we'll probably post this on it as well, maybe sometime next week. So just trying to really get the word out, and that hospital systems do have a choice, and they need to be made aware of what the impact is going to be if whatever system they upgrade to in the NICU specifically.
Yeah.
I just wanted to mention one more thing before we get off the call here, that NutriSafe 2 meets all of the California mandates, all of the AB, I forget the number, but it's a reverse locking lure system. So if administration says, well, we have to switch to ENFit due to California mandates or laws, and nowhere in that mandate or the law says ENFit. It says reverse locking lure system. So LAC, USC, all of you Silmar have been compliant. They are compliant, and they will continue to be compliant using NutriSafe 2, even if the rest of the hospital switches to ENFit. It's a reverse locking lure system. So Janet, if you were to do the same, your department would be compliant with all the California regulations.
Okay.
And I actually have a letter from the FDA saying that the recommendation is to go to an ISO -1 or -3 system, and
Right.
NS2 is a -1 compliant ISO system. So I can send that to you as well if you think that would be useful.
Okay. Yeah.
Yeah, I think that's a great point, that ISMP, the FDA have both kept it general with ISO 80369-1 or 3. No one is honing in. And the previous version of the ISMP specifically said ENFit, and that verbiage has been removed. So it is ISO compliant devices, and that's an important distinction.
Right.
Yes.
He had some other reps and companies that said like you have to do this by law, and they felt like they were handcuffed along the way, if you will.
Yeah.
So just want to give the education.
Yeah, I mean, we at my previous institution, we were told it would be a joint commission requirement. We needed to get ahead of it, and yada yada yada. And then in talks I've had with the people at Joint Commission, it has been, we will not endorse a single brand. We will endorse devices that reduce the risk of misconnections, not any single brand. So you're not married to Infit by any means if that doesn't fit your population's needs.
And was there any mention of color in those regulations? That was something that we were concerned about last time.
As far as I know, there is no mention of color. It's not purple or orange. You can have either or. In Europe, it is mandated that it be purple. But in the US here, you can have purple or orange. And if you have an enteral feeding pump, let's say you have an orange enteral feeding pump, but you have a purple disposable system, let us know and we could probably change out those plates on the enteral feeding pump for you to match the system. But no, there hasn't been any recommendation on color, Michelle.
Thank you.
Karen, I know that you're still on the call. Do you have any questions? I know this is, you've been on the webinars and we're going to see you in a couple days, but anything that you'd like to ask Dr. Omara before we end this little meeting here?
I don't think so. I apologize. I actually have not been on the call. I've had a medical emergency I had to run off to and I couldn't disconnect. So, but I've seen most of Dr. Omara's webinars and I think I've had most of my questions previously answered. So thank you again.
Great. I appreciate you getting on. It was a last minute thing. And so I appreciate you jumping on the call.
Indeed.
Okay, are there any other questions? Janet, Michelle, Ty, Evan, Mary, everybody?
Well, I think Evan and I will be in touch with the facilities and Janet, Michelle, and Sue, and make sure they have what they need. And Janet, to see if there's any extra steps that you want from me or to take to, I don't know, samples or whatever, because it's obviously new to you and not new to the others. But Evan and I are here to support you guys in whatever the next steps might be.
Any way, shape, or form, absolutely. And then I guess I will get with Susan probably first, and give her the information, and so maybe get with Michelle and see what she feels is the best way to present it to her, just so she has it, just as it's like days, weeks away for her in terms of it being an issue.
You can tell her it's not insurmountable because we did it at UF. We were down, we had the whole warehouse full of supplies and we were about a week and a half, 2 weeks out from our go live and stopped it. So she can.
That is great news. I'm happy to hear that.
Good news.
Okay, well, thank you everybody for getting on the call. Dr. Omara, thank you so much for all of your information. And I will get this recording out to everyone as soon as I possibly can.
Great.
All right. Thank you everybody for
Enjoy,
getting
guys.
on.
Thanks for coming, Michelle.
Appreciate it.
Appreciate it.
Thank you.
Thanks for
Yeah.
listening.
Bye.
Appreciate it. Bye-bye.
Bye-bye.
Thank you.